tell everybody a little bit about why we have set this up. And it was really discussions with the young nephrologists to produce an environment where they could present cases, present and connect with other nephrologists in Africa, and actually just develop networks and be in an environment where we can all learn from one another. So actually, I'm incredibly happy to be part of this, and I'm really excited for our speaker and our consultant nephrologist today who have come together to teach us all. So firstly, I'll just mention the housekeeping notes. We are attending the webinar. If you are here, you're attending a webinar of a case of tricky lupus and the discussion around it. Please try to join from a quiet, distraction-free zone. Please ensure that your microphone is muted when you join and your camera is turned off into the virtual meeting room. A chat box is available for comments and questions. Myself and Dr. Davidson, who is actually going to help me co-chair this evening, and Dr. Davidson is one of the members of the young nephrologists. We will actually try to assist with the questions in the group. So it really gives me extreme pleasure today to firstly introduce our presenter. So our presenter today is Dr. Sudha Kosh. She's a consultant nephrologist at Regency Medical Center, Dar es Salaam in Tanzania. And I must say we have had ISN fellows from Tanzania, so we are really feeling very warm and excited to have you on board today. She's a member of the Nephrology Exco there. She is an old ISN fellow, so we also train a lot, and I know we're very excited to be part of the ISN fellowship community. And she did her fellowship in India, and she was mentored by Prof. Georgie Abram. So she has quite a few accolades, but one that's recently caught my attention, what she's actually recently published in the Handbook of Renal Transplant in Developing Countries, which is really quite amazing, Sudha. So I will also I will introduce you now, and you can do your case, and then I'll introduce Dr. Kasimji, who's going to be the consultant providing input. So thank you so much, Sudha, for joining us today. We're really, really happy to have you. And yeah, let's get the ball rolling and let's get started.
Thank you so much for your kind introduction. And first of all, can you see the screen?
Sudha, we can see the screen. You now just need to put it on your presenter view.
Yeah. Is it okay now?
It's perfect, 100% perfect.
Okay, thank you so much. Okay, so first of all, Happy New Year. We really pray that the new year will bring a lot of good fortune for everyone, peace and happiness, and a very good evening to all from Tanzania. So today, I would like to first thank AFRAN and the Educational Committee to give me this opportunity to present in this great forum to share our knowledge and the day-to-day challenges we get as a nephrology caregiver. So I will take you through a tricky case of lupus, which I came across recently. So this is a 32 years female African origin who referred to our center with main complaints of progressive body swelling over 1.5 months. Initially, the swelling started on her face, but later on progressed to the lower limbs. She also reported a persistent low-grade fever for 1 week, flu-like symptoms with a chesty cough, which worsened over 3 days. The patient reported to have some dyspeptic symptoms with nausea, mild joint pains on and off, but she denied any history of skin rash or any significant weight loss or hair fall. Prior to coming to our center, she went to a primary care where the GP suspected her to have a nephrotic syndrome and started her already on steroids, high-dose furosemide and metolazone. She did not have any other chronic illnesses like diabetes or hypertension. She was not a smoker or alcoholic. She did not give any history of chronic use of NSAIDs or any herbal medications or illicit drugs. So on physical examination, she looked quite lethargic. She had gross edema of the lower limbs and the face. She was pale and afebrile. On auscultations, we found some fine crepes on the left side of her chest. The rest of the examination was essentially normal. The vital-wise, she was quite hypotensive, tachycardic, but she was maintaining well in room air, so she did not require any oxygen supplement. The preliminary evaluation showed she had a mild to moderate degree of anemia with lymphopenia. The CRP and ESR were elevated. The urine routine analysis showed she had gross proteinuria and also microscopic hematuria. And there were some fine granular cast were shown in the urine as well. A 24 hours urine protein quantification was ordered, and which revealed that she had a nephrotic range of proteinuria. She also had a significantly low serum albumin and a high cholesterol level. So all these things put together, we already came to know that she has a full-fledged nephrotic syndrome. The malaria profile and the virology screening were negative. So we also looked for some imaging studies. The chest X-ray showed there is a left basal pneumonic process, but rest of the other imaging studies were quite normal. Coming to an era where when you have flu and cough, we already think it could be a viral pneumonia. We also tested her for COVID-19, and we did some autoimmune screening as well. The COVID-19 PCR took about 48 hours, and for that, we kept her in the COVID suspected ward. So we know that we had a female with a nephrotic syndrome, but we did not know what is the cause for the nephrotic syndrome. But she currently having a pneumonia and hypotension, which could be attributed to the sepsis or overuse of diuretics. So in the ward, we manage her accordingly. Temporarily, we held the diuretics. We gave her some IV antibiotics, IV pantoprazole for her dyspepsia. As we know that we suspected her as COVID-19 patient, we started her on IV dexamethasone and later on switched to prednisolone tablets. With the treatment, she recovered quite well and was discharged after 3 days. And she was asked to attend our nephrology outpatient clinic. After a week, when she came to me, I had one good news to give her and one bad news. The good news was that her chest symptoms were completely gone. The X-ray, the opacities were cleared, but still she had a persistent proteinuria of 3+, and the ANA came strongly positive with a very high titer. The dsDNA and ANCA were negative. Due to the financial constraints, we could not do the whole ENA profile. So I talked to the patient. I explained her that she has new onset lupus, and maybe that is the cause for her kidney disease. And in my mind, I was going through that most likely the patient has a proliferative lupus or a membranous lupus presenting with as a nephrotic syndrome. But when I did the biopsy, it struck me with a surprise. The biopsy findings were quite different what I apprehend. Like all light microscopy, the glomeruli looked almost normal with a mild increase of mesangial matrix. The tubules were a little bit of cloudy with some mild interstitial edema. The vessels had some hyaline thickening. That's all. So there was not much proliferation or subendothelial cellularity, hypercellularity, nothing was there. And immunofluorescence also came negative. Electron microscopy, unfortunately, we could not do it because it is not available here. So with this scenario, that's what make the case more tricky, because so far whenever I biopsied lupus patient, it came either stage 3, 4, or 5. So this is the first time I'm seeing a patient with lupus, but the biopsy was not typical of a proliferative lupus. Hence, it makes a tricky case. So here, some of her slides, you can see the glomeruli, they looked quite normal. There is mild interstitial edema. Here you can appreciate more better. And also the GMS stain showed there was no basement membrane thickening. So what came to our mind, or the conclusion, is the patient is having, though she has lupus, but she has a minimal change disease or an unsampled FSGS. This is the first time I came across such case with a lupus patient, and that's why it was very interesting for me. Unlike the other lupus patients where we do the induction, I preferred to just start with prednisolone and hydroxychloroquine with some supportive treatment for this patient with telmisartan, atorvastatin, aspirin, and calcium supplementation. And after 8 weeks, I was very happy with the result, and the proteinuria reduced significantly to 1+, and even the hematuria reduced with quite a bit of significant improvements of other parameters. Though the patient had some side effects with steroid, like she had a Cushingoid feature, she had tremors, she also had some severe dyspeptic symptoms and hyperglycemic episodes. Keeping all these things in mind, I started to taper the steroid slowly. But unfortunately, for the next visit after 4 weeks, she presented with recurrence of the edema, and the proteinuria increased again to 3+ with 2+ of blood. So I had this dilemma in my mind that is it a steroid dependent nephrotic syndrome versus is there a concomitant new onset proliferative lupus? So these things, as nephrologists, we always have these dilemmas. At this point of time, I decided to add MMF 1 gram twice a day. Along with the other management, the prednisolone, I continued to taper it down. The statin, telmisartan, and calcium supplementation were ongoing. So after 2 months, I saw her recently 2 weeks back, and I was very happy with the results. The urine protein was nil, though she still has some microscopic hematuria, and all the other parameters like albumin level and cholesterol, they came to the normal ranges. So this was the case I got into, and during the whole process, there were several doubts or questions was boggling in my mind, that how common is that MCD in lupus patients, because this was first time for me to come across. And in that cases, what should be the management plan? If the proteinuria flares, should we repeat the biopsy? And what is the usual prognosis of this kind of patients? And in a resource limited settings where EM is not available, how we know more about the lupus podocytopathies, which is a current interest in the field of nephrology. So my next speaker, I think definitely will explain them more. But for me, this is the case I had, and I'm glad to share with you all. Thank you so much.
Thank you so much, Sudha, for that very interesting case. I'm going to now introduce our next speaker. So I want to thank Dr. Sahira Kasimji, who's actually a physician and nephrologist from Helen Joseph Hospital in Johannesburg, South Africa. And really thank you so much, Sahira, for giving up time this evening to be the consultant on this case. A little bit more about Sahira. She's actually one of the members of the South African Nephrology Society, and also she's one of the members of the AFRAN co-committee, hemodialysis co-committee. So really we're trying to extend our connections through within Africa. She has a particular interest in lupus, so we're really grateful for her contribution today. So Sahira, thank you very much again, and we're looking forward to hearing your discussion about this very tricky case.
Thank you, Nikki. Good evening, everyone. Thanks for the opportunity, and thanks to Dr. Ghosh for a really interesting case presentation. Just as a background, in terms of lupus nephritis, we know that the incidence of biopsy-proven lupus nephritis differs among different geographical areas, and it's somewhere between 25 to 40% of patients with SLE have lupus nephritis. Renal involvement is common. 60% of cases present quite early, and most of the studies show that the risk of lupus nephritis is highest in the first 5 years following SLE diagnosis. As this patient showed us, she had renal involvement very early on. The incidence and prevalence is not very well known in Africa, but we know that lupus nephritis is one of the commonest causes of secondary glomerular disease in most biopsy series. At our own hospital, when we audited biopsies done over the last 5 years, lupus nephritis was the commonest GN, and it comprised over 25% of our cases. So getting back to the case, so we have a young female, she presented with a pneumonia and she has newly diagnosed lupus. So we can postulate that the pneumonia was possibly immune dysregulation from lupus itself or from the nephrotic syndrome, where there's renal loss of complements and immunoglobulins. We know the humoral and cell-mediated immunity is also affected. These patients have a high risk for bacterial infection, particularly spontaneous bacterial peritonitis if they have ascites with nephrotic syndrome. So as Sudha said, it was a clear nephrotic syndrome, very low albumin, high cholesterol, very proteinuric, minimal hematuria, normal renal function. The other pertinent questions that were asked was, there was no nephrotoxin use. There was no recent COVID-19 vaccine because we are aware of many glomerulonephritides being triggered by the vaccine. The virology was negative. The patient wasn't pregnant. So this is a patient with lupus that is nephrotic, normal renal function, and normally we would think, this is probably a class 5 lupus nephritis. But as she said, the renal biopsy findings were a bit surprising. So there was only just mild mesangial involvement. It was not membranous. There was no proliferative change. And interestingly, immunofluorescence was negative. Unfortunately, electron microscopy was not available in Sudha's setting, so it was not performed. So this next slide shows us the ISN classification of lupus nephritis, the one that you're all familiar with, class 1 to 6. And over the years, there have been several criticisms of this classification, including that it is quite glomerulocentric. It relies heavily on light microscopy findings and not the underlying pathogenesis of the disease process. It also doesn't adequately consider certain parts of the glom, like tubulointerstitial injury, vascular lesions, and podocytopathies. So in this patient, the biopsy could possibly fit into a 1-2, but the clinical presentation didn't match a lupus nephritis class 1 or 2. So in terms of the updated guidelines from KDIGO, there is guidance on what to do with a patient whose histology looks like class 1 or 2, but the patient is nephrotic, which is out of keeping. So ideally, if you have access to it, electron microscopy would be useful. But in the absence of electron microscopy, it suggests treating the patient as minimal change disease, which in the setting of lupus falls under the umbrella of a lupus podocytopathy, which is the probable diagnosis in this patient. And I will spend a few slides doing an overview of lupus podocytopathy and relating it to this patient. So Lupus podocytopathy is not a disease where we know a lot and there's not robust evidence like the other classes of lupus nephritis. Most of the literature is retrospective, case series or case reports, and the largest case series is 50.
I didn't catch that. Could you?
So going back to podocyte anatomy for the fellows that are on the call. So we know that podocytes are terminally differentiated epithelial cells, and the processes extend to wrap around the basement membrane of glomerular capillaries. Their foot processes contain extensive actin cytoskeleton and interdigitate with the foot process of the podocytes next to them. And between them, there's a slit diaphragm, which acts as a selective filter. So anything that directly damages this, basically as an end product, causes foot process damage and effacement and leakage of protein. So is this a new entity, and when was it first described? In 2002, there were two groups, Dube and Hertig, and they both described actually 18 cases of patients that had minimal change disease and FSGS, and they had recently been diagnosed with SLE and they had nephrotic syndrome. In all these patients, there were no sub-epi or subendothelial deposits, and 44% of these patients had mesangial deposits, suggestive of a class 1 or class 2. And this observation that the onset of the nephrotic syndrome correlated with the onset of the clinical features of lupus led to the idea that they are not two coexisting diseases, but that the podocytopathy is actually the result of active lupus, creating the term lupus podocytopathy. The largest case series comes from, sorry about my sister. The largest case series comes from China. They have 50 patients with lupus nephritis of 3,750 biopsies. 13 had minimal change disease, 28 had mesangial proliferation, and there were FSGS in 9 patients. All of these patients had a nephrotic syndrome. There were AKI in 34%, mostly the FSGS subtype. There was a high rate of remission within 4 weeks, but there was also a high relapse rate. And what they found was that the minimal change disease mesangial group actually did better. The clinical manifestations of these patients, they had hematological disorders, as is often associated with lupus. They had some extrarenal manifestations, not many, but the commonest one was malar rash. In terms of serological markers, ANA was positive in all, and about 25% had double-stranded DNA and 32% had Smith positivity. Low C3 was interestingly found in 68%. So, there's been a proposed diagnostic criteria. Sorry, it's a difficult to read slide, but, just here for completeness sake as to what the criteria are. So in terms of clinical, you must be diagnosed with lupus and have nephrotic range proteinuria. It can be accompanied by AKI, and you must exclude nephrotoxic medications like NSAIDs. On light microscopy, you will see either minimal change or mesangial-proliferative or an FSGS picture, and there won't be sub-epi or subendothelial deposits. And immunofluorescence, they won't be capillary immune deposits. The only thing that may light up on immunofluorescence is the mesangial areas. Electron microscopy actually mostly clinches this diagnosis when it shows foot process effacement of more than 50%, and typically it's more than 70%. And the criteria say to diagnose lupus podocytopathy, you need all 4. And I think our patient fits in the absence of the electron microscopy. So why is it important to actually differentiate lupus podocytopathy from a class 1 or 2? Should you not just treat it as a class 1 or 2 with nephrotic syndrome? Do they behave differently? So a group looked at 125 biopsies of lupus nephritis patients that showed mesangial proliferation with mesangial immune deposits. And they divided these cases into a podocytopathy group, and that comprised 31 patients. This group had foot process effacement more than 50% and nephrotic syndrome. And the rest that didn't have these features were clumped into the mesangial group. What they found was that the podocytopathy group presented more frequently with renal involvement as the first manifestation of SLE, interestingly, like our patient. They had less extrarenal involvement, less hematuria. And what we can see on the the proteinuria between the two groups, there's a significant difference in the degree of proteinuria. So we see 5.57 grams in the podocytopathy group compared to 0.69 grams in the mesangial group. And it supports the idea that lupus podocytopathy should be a separate clinical diagnosis and classified separately from class 1 or 2. And what is evident from the study is that the degree of proteinuria is associated with the extent of foot processing instead of mesangial proliferation or immune complex deposits. And so the predominance of a nephrotic cause highlights lupus podocytopathy as the primary diagnosis. And you can make an additional or secondary diagnosis of mesangial proliferative lupus nephritis. So it's actually suggested that it should come into the ISN classification after class 2 lupus nephritis. So this lupus podocytopathy has different histological subtypes, quite simple. It's minimal change disease, it's FSGS, or it's mesangial proliferative, which is a class 1 or 2 with podocytopathy. So why also differentiate subtypes? They found that the FSGS has much worse outcomes, which are higher rate of hypertension and acute kidney injury, more severe tubulointerstitial involvement. It's less likely to respond to therapy, and remission occurs later. And that's important because it will change how you manage the patient. If you know that early on, you're more likely to treat more aggressively. These are just some morphological features of lupus podocytopathy. In the first picture, A, that's just a picture of minimal change disease. B shows mesangial proliferation. You can see the dark pink areas. C is focal segmental glomerulosclerosis, and it's a particular type, collapsing type, which has a particularly poor prognosis. And then I'll jump to F, which is foot process effacement that you can see on electron microscopy. This is just another slide of a normal light microscopy and foot process effacement. So what is the pathogenesis of this disease? If you go back to out of lupus podocytopathy and just generally podocytopathies, we normally, the old classification is to say, GNs are like primary or secondary, for instance, primary FSGS or secondary FSGS. And there's a move away from that to say that we should rather look at the pathogenesis-based classification. So for instance, if you say it's a permeability factor mediated podocytopathy, in FSGS, that's super, but, a circulating factor causes podocyte injury, and that presents with a sudden onset nephrotic syndrome. You get toxin mediated podocytopathies. APOL1 can be related to this. You get genetic mutations, and then a true secondary FSGS would be something like a hyperfiltration mediated FSGS. Okay, so that's just away from lupus podocytopathy, but just generally podocytopathies. And then in terms of lupus podocytopathy, it seems to be unrelated to immune complex formation. So we know that because there's an absence of deposits in the glomerular capillary walls, and there's presence of severe foot process effacement. And it suggests a mechanism that seems to be quite independent of the typical immune complex deposition that's associated with lupus nephritis. The foot process effacement may be explained by a direct injury associated with T cell dysfunction, cytokines, lymphokines that damage the podocyte. Other theories include potential circulating factors. So the circulating permeability factor theory in podocytopathies actually has a very interesting history. In 1974, a physician noticed that the nephrotic syndrome associated with Hodgkin's lymphoma, which is probably a minimal change, often resolved in patients who contracted measles, and measles is a virus that dampens the T cell activity. And it was thought that abnormal T cell production of a circulating permeability factor may actually mediate the podocyte injury. And, there may be a similar pathogenesis for lupus podocytopathy that has been speculated for minimal change. Why are these patients getting a minimal change picture? So T and B cell dysfunction is considered to cause altered glomerular permeability. A lot of the cytokines implicated, particularly IL13, is released during SLE flare due to dysregulated cells and in one of the possible causes. And it seems that this IL13 can directly damage podocytes. IL13 induces CD80 expression, if you can see here, CD80 expression in podocytes, and it results in foot process effacement and proteinuria. And IL10 and 13 have an important role in autoantibody production in SLE. So you can see T cell abnormalities seem to underline both these disorders, and it's a possibly unifying pathogenic mechanism in the development of SLE, of minimal change disease in SLE. So in terms of management strategies, the goal of treatment of any podocytopathy is resolution of the nephrotic syndrome and prevention of kidney failure. An achievement of proteinuria remission is associated with reduction of kidney failure. So going back to KDIGO, they suggest, we know that it's a disease that has good response to steroids, more than 90% response to high dose steroids within a month, but there appears to be a significant risk of relapse. And optimal duration is not known, and there can be maintenance therapy with any of the immunosuppressants. So a treatment strategy that has been outlined specifically is using steroids, 1 milligram per kilogram daily, or maximum of 80 milligrams a day for a minimum of 4 weeks and a maximum of 16 weeks. It's like an FSGS type of regimen. And to taper it slowly over 6 months after remission. You should also use a steroid sparing agent, and it's not specific which one works the best. MMF has been used, AZA, cyclophosphamide. CNIs seem to be useful for severe foot process effacement, and I will discuss this later. Then there's a role for severe relapsing cases for rituximab use. So why not just use steroids alone, and why didn't it work in this patient when it was used alone? So a group looked at 50 patients with lupus, and they received steroids alone or steroids plus additional immunosuppressive agents. It's a very heterogeneous group. So they received all sorts of things like tacrolimus, IV cyclophosphamide. There was not one standard immunosuppressive agent that was added. And the treatment response and relapse rate in the two groups were analyzed. And we can see that the steroid group induced remission in all patients with minimal change disease or mesangial-proliferative disease. So we know it's very steroid sensitive, but it only in 4 of the 6 patients with FSGS. I mean, these are small numbers, but we can see that FSGS, is tending to be a disease that is not necessarily as steroid sensitive as minimal change. And the steroid combined with the immunosuppressive regimen increased the remission rate. The relapse rate was also higher in just the steroid group alone. Okay. In terms of the outcome, so as I said, glucocorticoid sensitive entity, steroids alone or combined induce remission in over 90%. The median time to remission is actually quite quick. It's about 4 weeks, and complete remission rate was 76%. However, more than half of the patients have relapses of renal disease, and these tend to be concurrent with extrarenal manifestations or serological activity of SLE. Maintenance treatment with steroids alone resulted in relapse of 89%, and steroids in combination with additional immunosuppressant markedly reduced the relapse rate by more than 50%, which is what we saw in the patient presented. She relapsed very quickly on tapering of steroids and responded very well to combined steroid and MMF after a 2-month review. The FSGS subtype shows a much worse response to steroids. They have a lower rate of complete remission. There's a percentage of patients that don't respond at all, a longer time to remission. There's a collapsing variant that I showed you a picture of that seems to be more aggressive and could require more immunosuppression. And APOL1 high-risk variants with lupus and the collapsing lesions may not respond at all to immunosuppression. So it's not necessarily a completely benign disease. The role for calcineurin inhibitors would make sense. So in patients with greater foot process width, complete remission rates were significantly higher, and the long-term renal outcome was better in the group with CNIs compared with other regimens. So we know that CNIs can reduce proteinuria by non-immunologic mechanisms, and you can see that over here. So what they do is that they inhibit the dephosphorylation of synaptopodin and have positive effects on the actin cytoskeleton. So they stabilize the podocyte by inhibiting the dephosphorylation of synaptopodin. Over here, so this is the general treatment of lupus nephritis going through the classes. And if you go right to the bottom here, podocyte injury, there is a suggestion that newer agents can be used. Retoximab or abatacept might have a role in the treatment of patients with quite severe podocyte injury. Retoximab has also been recommended for maintenance treatment in patients with recurrent relapses, but this is purely based on observational and retrospective studies. In this slide, you can see, where rituximab works, a B-cell depleting agent, where abatacept works, and then where the CNIs work, which is at the podocyte. So abatacept is a co-stimulatory inhibitor, and it targets CD80 on the surface of dendritic cells. And basically what it does is it attenuates T cell responses. And then here, this is interesting. So rituximab, it seems to be useful beyond its B cell depletion. So persistent remission of proteinuria after treatment with rituximab has sparked renewed interest in the role of B cells in these disorders. So rituximab may have effects independent of the effects on B cells. And they've been reported to stabilize the podocyte actin cytoskeleton through its binding to this SMPDL3B over here. So that's where it acts and stabilizes the podocyte cytoskeleton, and therefore it would reduce proteinuria. So Dr. Ghosh asked the question about rebiopsy in this patient. So her patient has responded well. So currently, it's probably not necessary. She seems to be, really doing well. If a patient with the lupus podocytopathy has a clinical presentation to suggest a change of class, for instance, like worsening GFR or nephritic picture or non-response to treatment, it probably is useful to rebiopsy them. And then in this larger series, after 13 patients that relapsed, they biopsied all of them, and 6 of them had transitioned to an immune complex mediated form of lupus. So 3 went to class 4 and 3 became a class 5. So, lupus actually can transition from one class to the other. We all are aware of patients that, on repeat biopsy change their class. So it's definitely something to be cognizant of when you're following up your patient. And then in the reverse, there's case reports of a podocytopathy after treatment of an immune complex lupus nephritis. And just as a basic general rule, don't forget your adjuvant therapy. So chloroquine use is important in all classes. It decreases relapse rates. These patients are on high dose steroids, so bone protective therapy, using ACE inhibitors as well, avoiding nephrotoxic drugs, mostly all young females, so consider reproductive health and teratogenic drugs that we use, and prophylaxis for infections because we're giving them high dose immunosuppression. So just in summary, lupus podocytopathy does seem to be a distinct entity, and the criteria are a diagnosis of lupus plus a full nephrotic syndrome. On biopsy on light microscopy, we'll see either normal gloms or segmental sclerosis plus minus mesangial involvement. There should be no deposits or only mesangial deposits. And electron microscopy usually shows more than 50, but it's usually more than 70% foot process effacement. 2 major entities are minimal change mesangial and an FSGS, which seems to be less steroid sensitive. In general, it's very steroid sensitive, but there's a clear role for adding a second immunosuppressant. That's it on my side.
So, Dr. Kasimji, thank you so much. That was absolutely awesome. It was really a fantastic focused discussion around the case. So really, thank you. It was awesome. I don't know if there's any questions in the chat yet, but I certainly have a couple of questions myself to get the ball rolling. And I'm sure Sudha probably has some questions as well. So my first question actually to you is, with the lupus podocytopathy, is there also association with low complement levels? Is there a low complement? And if you allow me a second cheeky question, this patient didn't have a positive anti-double-stranded DNA, and I just wanted to know I know they were ANA positive, but it appeared that the anti-double-stranded DNA was not positive. So just 2 thoughts on that, Zahira.
So in that largest case series, 6% of patients,
I can't help you with that on Mac.
Sorry, again. On this largest case series, troubling me. It showed that only 26% of patients had double-stranded positivity, and low complements was found in about 63%. So it is you do find low complements, but not all are double-stranded positive, and Smith positivity was 32%. So yeah, it's not necessarily like how we see proliferative nephritis, but also there's clear complement involvement.
Excellent. Sudha, thank you very much for that. Sudha, have you got some questions about your case?
I wrote the questions, what I had in my mind. And I was just thinking, like, how long the immunosuppression should be, continued in these cases. Like, what we do for the lupus in the same way, or we can, just for 6 months, or what should be the timeline for continuing the MMF?
So there's no clear guidelines, but they say at least wean your steroids slowly over 6 months. But we know from our experience with even membranous nephropathy, the maintenance phase is at least almost 18 to 24 months. It's long, and it seems like this is a kind of disease that has frequent relapses. So you'll probably wean the steroids and the MMF and probably end up with a relapse. So I would rather go slower, and even a year at least, I would think.
Because we see some of the lupus patients, like the normal proliferative lupus, they need even 2 years to get the proper remission, So I would think also for them at least 1 year to continue, right?
No, I think absolutely a year, if not longer. I think they respond very quickly, but as soon as you withdraw the immune suppression, they relapse very quickly. So we want to prevent, ongoing kidney damage every time that happens. So, yeah.
Another question I have, like, I kept the patient on telmisartan, but is there any role really of ACE inhibitors or ARBs in this kind of patients, or they can be still used as adjuvant therapy?
I think it's as a general, anti-proteinuric drug, it's used, but it's not specifically used in this entity. And when we look at things like steroid-sensitive nephrotic syndromes in children, etc., or the genetic forms, there's not such a major role for ACE inhibitors like we generally use it. And this may fall in somewhere there, but I think, if her blood pressure will tolerate it, I would go for it and definitely use it.
Okay, thank you.
Zahira, we have some questions that are coming through the chat now. Firstly, thank you for an awesome presentation. And I think the one thing that struck me the most from this presentation was, if you're working in a place that doesn't have renal biopsy or special staining, the one way you need to start thinking about it is if you have a normal creatinine and you have a very high proteinuria, that's out of keeping to a class 1 or class 2. So that's a very nice kind of red flag to think through. The first question that we have is along those lines. The question is, how frequently is lupus podocytopathy compared to class 1 or 2? And the second part of that question is that, given that the pathogenesis is mostly on EM, how can we diagnose this in patients where EM and immunofluorescence is not available?
So in terms of how common it is, it was 1.3% of all biopsies. So it's very, very uncommon compared to the other groups. And in terms of how to diagnose it, I think it's to have an index of suspicion. So if someone is ANA positive and they look like they have a class 1 or 2. So, the typical thing with lupus is this mesangial involvement. So if they have this mesangial involvement, that's quite a simple stain. I mean, that's a PAS stain on light microscopy. You should be able to get hold of that. Immunofluorescence is typically negative in the usual areas, except the mesangium. And I think, you'd be suspecting, if you suspect, it's either normal or just mesangial with negative immunofluorescence in this setting and nephrotic syndrome, even without EM, I think you can, you can make the diagnosis. And probably your management would be the same as well. So.
Well, that's great. Thank you.
Thank you. So we've got another question, so we'll just alternate them, B.
Cool.
So firstly, thanks to the presenters. And the question was, MMF appears to be effective in lupus podocytopathy. However, this differs from treatment used in the management in minimal change FSGS of drugs that reverse podocyte secreted FPE or stabilize the actin podocyte secreted skeleton. Is it perhaps the actual pathogenesis that's unclear in this case, or we don't have enough evidence yet in terms of how to treat lupus podocytopathy? Just your thoughts, if you've got thoughts on this. Zahira.
So we know that there's a heavy T cell involvement in the pathogenesis of lupus podocytopathy, and it may be that MMF is attenuating this, and that's how it works. But specifically, it's not been seen as, you know, the drug to use. I think the only drug that's been sort of highlighted as to use in severe cases would be calcineurin inhibitors, particularly for its specific action on the podocytes. But in terms of the immunosuppression, there was not mention of, say, you know, one being like MMF being better than cyclophosphamide, etc. But, you know, my thinking would be it's T cell effects as mediating this podocyte injury.
Yeah.
So we have some sneaky questions here from not registrars, but consultants. And so these are quite hard questions. So the one question is there any suggestion or evidence that plasma exchange may remove circulating factors?
So I read one case that was described where it was used, but it was quite a florid case. The patient had renal failure involvement, renal failure, etc. And they did use plasma exchange with good effect. So maybe in that case, there was a circulating factor. So there is definitely a thought that maybe there's a circulating factor involved that's not been identified.
And I have one question myself. In the cases with where Retoximab was getting used, did they specify the dose and how they administered it? In what time interval?
They gave the usual, 350 per meter squared dose.
And they did it monthly then?
They did it. They gave 2 doses, and I think it was 4 weeks apart.
Okay.
Yeah.
Okay. So we've got sorry, Zahira,
yes,
you could finish.
Yes. Sorry, I think it was a month or 2 apart, but that kind of Retoximab dose. Yeah.
There's another question just for clarity, just provide the actual difference between the lupus podocytopathy and class 5 lupus.
So there's no subepithelial deposits in a lupus podocytopathy, which is the hallmark of what a membranous or class 5 is, which on light microscopy, we'll see thickening of the basement membranes, you'll see the spikes. On immunofluorescence or electron microscopy, you'll see these subepithelial deposits. So that's not present in lupus podocytopathy. The major difference is on immunofluorescence, it will be negative, except maybe some mesangial involvement. So that's the major difference.
Great. Do you have the strength for one more question?
Sure.
So there's a question here about urine microscopy. So in places where biopsies are not readily available and there's an absence of immunofluorescence and EM, does urine microscopy help you to differentiate a lupus podocytopathy from the other patterns?
I mean, look, the other patterns would be proliferative, and then you'd expect an active urinary sediment with red blood cell casts. So you wouldn't expect that in lupus podocytopathy. So if you had no access to biopsy at all, I suppose the presentation, could mimic, you wouldn't be able to tell the difference between a class 5 and a lupus podocytopathy just on clinical presentation. They both present nephrotic with preserved renal function possibly. So that would be difficult to tell, but you could probably end up treating it the same with steroids and say MMF. So yeah.
And the second part to that question was, and I think you did mention it within your talk, or we have briefly chatted about it, is that can you still, or is this a reasonable thing to assigned to lupus if your ANA is positive and your double-stranded DNA is negative. And I think you did mention in the case series that there was quite a large number that had a negative anti-double-stranded DNA.
Yes, definitely. And the other interesting thing is that this is often the first presentation of lupus, can be renal, and you see the disease evolving, as in the next visit, you may suddenly see joint involvement or something different. So, it may evolve, but yes. And for the actual lupus criteria by the rheumatology societies, they just require ANA positivity.
And so here, just on that, do you think, is there documentation of the proportion of these patients that may actually become anti-double-stranded DNA positive?
And it wasn't commented on that series, no. I think the numbers are also quite small too.
Yeah. I think we might have actually exhausted our questions, but we've also probably exhausted our consultant as well. So I just want to really thank both of you, and also Bianca as well, for helping me co-chair this. But really, I've been it's been a fantastic session, and really look forward to ongoing sessions like this, and calling on all of you out there to help each other to learn about these tricky cases, and also help us to all connect with one another a little better. So I really think it was a very successful session, and I really want to thank you both. It was wonderful, and we'll see you at the next joint teaching and education and young nephrology meeting.
Thanks, Nikki.
Thank you.
Okay. See you. Thanks, B.
Bye.
Bye.
Bye. Bye.